during GUASCO 21, there was a really great session talking about personalized management of patients with non-muscle invasive bladder cancer. And I was invited to be, participate in a debate with one of my colleagues from Vancouver, Dr. Peter Black. And, he provided, so to a degree, so kind of the surgeon's perspective, intravesical therapy as the optimal therapy for patients with BCG unresponsive non-muscle invasive bladder cancer. I took the other opposite position. Well, systemic therapy, is the best option. And, and it was a really great debate. And, he made some really great points. And I hope that I countered with some great ones of my own. The bottom line is that we're trying to avoid a cystectomy. So whether it's intravesical or systemic, really the option, we should be focusing on options to avoid the cystectomy component, which is what the patients, are really trying to look for alternatives against. So the points that I made were that, from a systemic approach, in particular, immunotherapy with PD-1 antibodies, which is really what systemic therapy really is talking about. The points I really focused on were the fact that you hit the tumor, you hit the target, and the responses are much more reliable. And so what I mean by that is essentially that if you hit the target here is the immune system. Immunotherapy is treating the immune system. And a systemic drug circulates everywhere. It goes wherever blood goes. And so if you're trying to hit a biologically complex, heterogeneous, spatially, separated out, organ system, essentially the immune system, your best way to attack it or to address it is a systemic therapy, such as a PD-1 antibody. Get systemic immune activation against the cancer, and hopefully that leads to a complete response. Now, the other thing is that you hit the tumor, right? Because ultimately, if you engage the immune system systemically, then you're going to hit the tumor better, right? And the tumor is not just what's in the lining of the bladder, but it's also the microinvasive disease, the stuff that we worry about. That the whole reason we do a cystectomy in the first place is to be able to, to capture the disease before it becomes invasive and potentially metastatic. So why wouldn't you want to hit something with systemic therapy that's going to hit the tumor in all the potential sites, not just in the lumen and in the lining of the bladder, which is where most intravesical therapies work. And then lastly, the point I made was that complete responses are just much more reliable. So if you have a systemic therapy, hits the target, the immune system, which then is able to engage the tumor, if I see a complete response to systemic immunotherapy with a PD-1 antibody, I think that complete response, which is evaluated through cystoscopy, that is probably a much more reliable complete response, meaning true efficacy as compared to a luminally active treatment like intravesical chemotherapy, where yes, it's going to treat all the cancer that you can see in the lining of the bladder, but it's not going to address, the subepithelial, microinvasive, and potentially metastatic disease. And that's the whole reason, again, that you can't rely on those CRs and why we counsel patients about cystectomy in the first place. So I hope I tried to make that point in the debate. The other things that were, kind of counterpoints that people have said over the years about systemic therapy is what about the toxicity and what about financial toxicity? The rates of immune-related adverse events, they're real. We've studied this for a decade or more. And those high-grade events can happen. But I think with effective co-management along with medical oncologists, I think there's really a role for immunotherapy where patients are managed both by urologists and medical oncologists. We can do this very safely. And then the other issue is cost. There have been editorials and, a variety of studies that have looked at the costs of immunotherapy, in particular pembrolizumab or other PD-1 antibodies, estimated costs of $300,000 or more per year. Well, the fact is that, based on the study design, if after 3 months of treatment, patients didn't achieve a response, you stop treatment. And that's appropriate, right? So if you don't have a response, they need to stop and they should get a cystectomy or, counsel about other options. So it only costs more if it works. So for those patients to have, to cost that to the healthcare system, obviously is not a trivial point. It is an important point. But remember, that cost is only if it works. And for patients, that achieve a response, I still think this is quite meaningful, especially if they can avoid a cystectomy and achieve a complete response to immunotherapy.